Happy good afternoon to one and all present here. I, Ms. Asha Shanti, take this as a great pleasure to welcome you all for International Webinar Series 4 organized by Sri Abrami College of Physiotherapy. Movement is a medicine for creating a change in a person's physical, emotional, mental states. With this a great quote in this occasion, I heartily welcome our Chairman Dr. P. Periyaswamy sir, Sri Abrami Group of Institution and our Board of Directors, Dr. Kundavi Devi ma'am, Dr. Senthil Kumar sir, Dr. Balamurgan sir, Dr. Uma Devi ma'am, Dr. Sujirita ma'am. I welcome you all for this International Webinar Series 4. On behalf of Sri Abrami Institution, I am proud to welcome our most eminent speaker, Dr. Hernan Labao, lecturer, Department of Physiotherapy, INTI International University, Malaysia. He is going to present on the topic From Disability to Disability, current implications of mental practice on post-stroke balance and motor recovery. We are honored to have you with us today. Welcome you, sir. Now I heartily welcome our principal convener, Dr. R. Jayabadi ma'am. Welcome you, ma'am. Participants always makes the event more successful. Now I cordially welcome our students and delegates from various places who are registered for this International Webinar Series 4. Now I hand over the session to our principal to introduce our speaker.
A wonderful good afternoon, one and all. On behalf of Sri Abhinami Group of Institutions, I welcome you all for the International Webinar Series 4. I take this opportunity to thank our management, our chairman, Dr. P. Periyaswamy sir, who gave this platform to share the knowledge. And I thank our board of directors, Dr. Kundavi Devi ma'am, Dr. Sendil Kumar sir, Dr. Balamurgan sir, Dr. Uma Devi ma'am, Dr. Sucharita ma'am, who are constantly supporting for organizing this webinar series and making it a grand success. It gives me an immense pleasure in welcoming today's speaker, Dr. Hernan Labao, MSPT Neuro, lecturer, Department of Physiotherapy, INTI International University, Malaysia. Welcome you, sir. Sir has more than 15 years of academic experience in Philippines during the Association of Southeast Asian Pain Societies Congress 2019. He was awarded ASEAPS Young Scholar for his studies related to musculoskeletal pain. Mr. Labao is a member of Philippine Physical Therapy Association PPTA, the International Association for the Study of Pain IASP, the Philippine Association of Institutional Research, PAIR, and the International Association for Multidisciplinary Research. He will be a panel speaker for a focused group symposia for the World Confederation of Physical Therapy, BSPT Congress, which will be held on April 8 to 10 on 2021 in Dubai, UAE. He is also a scholar to attend the World Pain Congress organized by International Association for the Study of Pain, IASP, to be held in Amsterdam, the Netherlands by July 2021. So now I request Dr. Hernan to deliver his speech on topic From Disability to Disability, current implications of mental practice on post-stroke in balance and motor recovery. Welcome you, sir.
Thank you very much. Thank you very much, Professor Jayabarati, for that wonderful introduction. And I would say, Banakam to all of the participants of this webinar organized by Sri Abirami College of Physiotherapy. Let me share my PowerPoint to you all. I hope you can see my PowerPoint slides. Is it visible?
Yes, sir.
Okay. So good afternoon, everyone. And this topic is entitled From Disability to Disability, Current Implications of Mental Imagery or Mental Practice on Post-Stroke Balance and Motor Recovery or Motor Activity. I'll be talking about the current evidences of mental practice and how we can make use of these evidences to enable stroke patients recover from their impaired balance and motor activity, thus improving their functional abilities and overall health related quality of life. I think, therefore I am is a famous quote from a French philosopher René Descartes. Though the true meaning of this quote may seem controversial, it actually talks about the richness of the human mind guiding our logic, thinking, and even movement. Hence, our thinking can generally affect how our body responds and reacts. Mental practice refers to the mental or cognitive rehearsal of a skill without actual physical movement. In the early stages of learning, which is the cognitive phase, mental rehearsal is initially seen as the learner going through a skill or task and building up a mental picture of the expected performance in their mind, which is a cognitive process. Advanced performers can use mental practice to rehearse possible strategies or complex actions or sequences, thus almost pre-programming their effector systems and possibly helping with response preparation, reactions, and anticipation of movement. Mental imagery and mental practice is usually being used synonymous by some authors, but there are subtle differences between these two. Mental imagery refers to the active process by which humans relieve sensations with or without external stimuli. This cognitive operation can be performed in different or using different modalities such as visual, auditory, tactile, kinesthetic, olfactory, gustatory, or any combination of these. Motor imagery, on the other hand, is a general term that describes the process of imaging or imagining the movement of an object or a person. Mental practice, on the other hand, consists of a training method by which the internal reproduction of a given motor act is repeated extensively with the intention of improving performance. So, to put simply, the process of imagining a movement once or few times is called motor imagery or mental imagery. And the act of repeating the imagined movement several times with the intention of learning a new ability or performing a known skill is called mental practice. However, in the context of my presentation, I'll be presenting both with their current implications on motor performance. Mental imagery is further subdivided into internal and external imagery. Internal imagery happens when a person or an athlete visualize themselves as doing the task or visualize the tournaments in their mind. External imagery entails that an athlete or a performer visualize themselves from a third person's perspectives, like watching the other opponent or other person in a match, or using a video clips in order to visualize or see the tournament. So internal imagery is like having a camera on your head, so you can see what you would normally see when executing the skill. All right. Whereas external imagery, on the other hand, is when you are watching yourself complete the task or as if you are watching a video. So that is the difference between internal as well as external imagery. So in internal imagery, you get to see yourself, all right, looking at the different parts or different segments of your body as if there is a camera attached on your head. Whereas in external imagery, you seem to be watching yourself like you are watching a video. So mental practice has been extensively used in several fields. It has been extensively used in psychology, music, sports, education, and of course in medicine, particularly in sports and neurologic rehabilitation. It is commonly used in rehabilitation of stroke and Parkinson's disease patients in order to improve ability to set goals, self-efficacy, motivation and mood, and also to improve working memory. It was found to improve motor and strength-focused tasks. There are several theories related with how mental imagery influence motor activity. The first one is the psychoneuromuscular theory, which postulates that feedback generated during mental practice or during mental imagery can help strengthen motor program corresponding to a motor task. Psychobiological model, on the other hand, proposes that any psychological and physiological factor that increases potential motivation or increase maximal voluntary activation will improve strength performance, and that any psychological or physiological factors that reduce the potential motivation or MVA will undermine strength performance. Another important theory that is related with mental imagery would be mental imagery muscle strength relationship and motivational intensity theory. This theory proposes that an increase in maximal voluntary action and potential motivation are ultimate determinants of enhanced strength performance. These are some of the theories that are actually important when understanding the on how mental imagery can be applied into practice and how it can affect motor performance, how can it affect motivation, and how it can affect the overall activation of certain muscles in our body. So, what are the effects of mental imagery and mental practice on individuals with motor impairments? Mental imagery or motor imagery can lead to an improvement in muscle strength, movement speed, accuracy, and variability. Okay? There are certain factors that we need to consider in order for mental imagery or motor imagery to be effective. Since it relies on imagery modalities such as kinesthetic or visual, imagine or actual execution, and environment in which intervention is performed. Evidences of cortical plasticity during motor recovery is also another benefit of mental imagery. MI or mental imagery may integrate the feedbacks induced by sensory cues in order to facilitate cortical reorganization. In addition, evidence has shown that mental imagery lead to enhancement of the finger map area and volume in both cerebral hemispheres in a way that partly corrected the abnormal asymmetry between affected and non-affected hands of stroke patients. This can be a good evidence to support the use of mental imagery in order to improve certain motor activities, such as upper limb function. However, mental imagery may not be applicable in all stroke cases, especially those with chaotic motor imagery. Chaotic motor imagery is defined as an inability to perform motor imagery accurately, or if having preserved accuracy, demonstration of temporal uncoupling. Chaotic motor imagery tends to be limb specific, and it usually affects distal but not proximal movements in patients with parietal damage. So therefore, mental imagery may not be as applicable or may not be helpful in patients with stroke affecting specifically parietal lobe of the brain. And if you wanted to improve the functions of distal movements, or if you wanted to improve distal movements rather than proximal movements, then mental imagery or motor imagery may not be as effective as other techniques. So we have to choose other techniques. And if the damage to the brain primarily affects the parietal lobe, then motor imagery or mental practice may not be that effective, since there is this phenomenon or this particular physiologic um, fact of chaotic motor imagery. Now, this is a good representation of the phases of mental imagery or motor imagery, which highlighted the changes happening leading to cortical plasticity. Okay, mental imagery or the recovery following mental imagery and mental practice follows three phases: the initial phase, the learning phase, and the automatic phase. If we can still remember, according to the Fitz and Posner stages of motor skill learning, we have three stages: the cognitive stage, the associative stage, and the autonomous stage, which actually corresponds to the different stages of MI or mental imagery. There are cortical reorganization, long-term potentiation, and presynaptic inhibition processes that happens in these three phases. All of these will actually lead to a more refined, versatile, and automatic movement. And ultimately, mental imagery can actually help a person with stroke or a person who suffered from stroke recover, all right, and be able to perform their movement voluntarily and automatically. Mental imagery or motor and mental practice combined with conventional therapy can actually improve upper limb function. Okay, this can help stroke patients relearn tasks and transfer improvements necessary for daily functions. It can also produce changes in the quality and range of movement of the paretic arm by increasing its functionality. Overall, mental imagery or motor imagery can improve both upper and lower limb necessary for activity of daily life functions. Research has shown that there are several effects of motor imagery in order to improve motor activity of the upper limb. Mental practice that is guided with NMES showed superior result compared with conventional NMES. So it is more effective in combination with NMES in improving upper limb strength or upper limb function rather than conventional electrical stimulation alone. It is also an effective complementary therapy, either given with or without neurofeedback. It has direct effects on motor learning since it can promote awareness and active involvement of the patient. According to a Cochrane collaboration review, systematic review, there is a moderate evidence in terms of mental practice combined with physical rehabilitation, all right, compared with physical rehabilitation alone. It can provide improvement in arm movements and arm functions. In addition, mental imagery or motor imagery can play a role in the activation of neural networks in the premotor cortex, the parietal lobe, and the cerebellum. Another important benefit of motor imagery is on trunk control. Research has shown that motor imagery or mental imagery can lead to improvement in trunk impairment scale score. It can lead to an improved lower trunk lateral flexion and rotation. It can increase pelvic stability and enhances weight shifting ability. This has an important carryover effects on ADL and functional balance. And therefore, right, it is recommended that mental imagery or motor imagery focused on lateral flexion that will develop or that will help develop dynamic sitting and rotation, which is important for coordinated functions or coordinated activities of the trunk, is necessary. So what are the effective combinations? Several effective combinations are suggested based on systematic reviews. First one is mental imagery or motor imagery combined with physical practice. Motor imagery promotes cognitive adaptation process during motor learning that can lead to more elaborate representations than physical practice alone. So we have to combine physical practice with mental imagery. Another effective combination will be mental imagery combined with action observation. Now, action or observation is a dynamic state in which the observer can understand what the other is doing by simulating the actions and outcomes that are likely to follow from the observed motor act. Research has found that neurons are activated both during actual execution and during observation of the same task. This can actually play a role in terms of activating and reorganization of certain neurons in the brain, particularly during the process of neuroplasticity and motor recovery. This can lead to facilitation of corticospinal excitability during combined condition, which was muscle specific. Action observation is as just like what I have mentioned a while ago, is an important or is one of the newer techniques in neurorehabilitation. Okay. Action observation therapy is a top-down approach that is grounded in basic neuroscience and recent discovery of the mirror neuron system, as shown in this slide. Action observation therapy commonly includes action observation and action execution and allows the patient to safely practice movements and motor tasks. So, if mental imagery or motor imagery is combined with action observation therapy, then it can lead to better improvement in motor functions. In order for motor imagery with action observation to be effective, there are three effective combinations recommended. One, the observer should imagine the action while observing a third person performing the same type of action. So it's not just imagining the action, but they were also going to observe another person performing the same type of action. For example, I'm going to ask the patient to imagine that he's going to lift, all right? He's going to lift a glass of water. Then he should be observing another person who is also going to perform the same task or the same action. Another thing is that one or a patient could imagine an action in response to an observed movement, a combination called coordinated MI or motor imagery, and observation, also known as joint action. Meaning to say, the patient will be asked to repeat what is being done by the third person. First one, you just imagine and observe the third person performing the same action. Second one, the patient will have to do the same action as he or she is observing the third person doing that action. So it's more like you are mirroring, meaning to say you are mimicking, you are simulating, you are copying what the third person is doing. That is the second effective combination. And lastly, in order to facilitate a more dynamic motion, a more versatile, motor activity, a conflicting motor imagery and action observation may be used to further and understand the biases effect of mental imagery on observed actions and inversely. When you say conflicting, all right, we will ask the patient to lift, for example, to lift a glass of water while the person being observed is actually lowering, all right, or putting the glass of water to the on top of a table. So it is a conflicting MI and action observation. Conflicting motor imagery and action observation. You are observing a different thing, but the patient is imagining a different thing. All right. So that is a conflicting MI and action observation. Another effective combination would be motor imagery combined with cortical stimulation. Repetitive TMS and transcranial direct current stimulation can potentiate motor area and facilitate neuroplasticity during motor relearning. TDCS or transcranial direct current stimulation is a non-invasive brain stimulation techniques that apply a weak direct electrical current via the scalp to modulate cortical excitability in human brain in a painless and reversible way. Specifically, if MI is combined with cortical stimulation, it can activate the motor area and the left dorsolateral prefrontal cortex, which are important for long-term potentiation-like processes associated with motor learning. So what are the effects of mental imagery on balance? Research or evidences about motor imagery on balance has shown that it is not very risky, but an effective method of improving balance ability for both static and dynamic balance, especially to those who suffer from stroke. Literature suggests that it leads to an increased standing stability and gait velocity, increased weight bearing on the affected extremity, and increased position sense at the ankles, which are important in improving and maintaining a symmetrical stance posture. This seems to be due to an increased activation of neural networks in the premotor cortex, the parietal lobe, and the cerebellum, which are involved with motor planning and feedback of motion. Evidence suggests that there is brain reorganization following motor imagery training. Improvements in gait and other tasks involving coordinated lower limb and body movements are seen in people with stroke and Parkinson's disease. So what are the effects of motor imagery or mental imagery on gait parameters? MI can lead to increased standing stability and gait velocity, increased weight bearing on the affected extremity, increased position sense or proprioception specifically at the ankles, improve spatiotemporal gait parameters. Thus, it can lead to reduced fear of falling and promote earlier retraining of gait. This is according to a systematic review by Carrasco and Cantal Piedra in 2016. Improvement in pelvic stability, stepping ability, and weight shifting ability can therefore result to an overall improvement of functional balance, especially during walking. As physiotherapists, the ultimate measure of dynamic balance is for the patient to be able to walk. All right? So, our goal is not simply to improve balance, but to improve dynamic balance, which is necessary for walking. In addition, mental imagery can also strengthen motivation, which improves self confidence. And mental imagery plus kinematic and visual imagery can effectively improve motor function. Therefore, adding motor imagery training on gait training produce more significant enhancements in balance and gait abilities than gait training alone. Now, if we're going to look at it, all right, since motor imagery can actually improve gait training, than gait training alone, what we can do is actually to provide mental imagery or mental practice prior to our gait or balance training. This can actually enhance the patient's self-motivation and self-confidence and will also enhance the patient's ability to become mindful about the movement that has to be produced by the different segments of the body, which can improve foot placement, which can improve the patient's ability to control his or her ability to control the different segments of the limb, which are necessary for walking. Now, in healthy adult population, okay, previous studies also revealed that motor imagery can improve maximal voluntary strength if it is combined with physical practice. So the recommended dosage, all right, based on a systematic review with meta-analysis by Paravlek and colleagues in 2018 includes the following. So the training period should last for approximately 4 weeks, and it has to be 3 times per week. All right, the recommended set would be 2 to 3 sets per session, and it has to be repeated 25 times per set. Okay, a single session should last for approximately 15 minutes. All right, so this is true among healthy adult population. However, this particular dosage has not yet been proven among stroke patients. So that is actually an area or a potential area for research. Mental imagery, all right, can also lead to an improvement in muscle strength. Okay? Improvement in skilled movements after mental imagery training is due to adaptation of the motor cortex neurons. Research revealed that stronger cortical signals to the muscles are generated after repetitive mental attempts at maximal muscle activation. Motor imagery does not only produce improvement on motor execution, but also can increase muscle strength, which is specifically useful for strength-based tasks. So it is not only going to improve motor learning, it is not only going to improve balance as well as upper extremity functions and other parameters involving our motor recovery, but it can also improve muscle strength. Right? So any task that requires the strength, we can combine motor imagery or mental imagery. Research also revealed that internal imagery is more effective than external imagery in enhancing muscle force. It may also increase lower limb muscular force, all right, and help injured patients to recover motor functions faster. Short and long-term memories on motor relearning and performance are also enhanced following mental imagery training combined with physical practice. I need to emphasize that mental imagery or mental practice alone is not effective. We have to use the operative word mental practice combined with physical practice, combined with um, conventional therapy or conventional rehabilitation. What makes our practice more extraordinary is to add that extra to the ordinary things that we do. And what mental imagery or motor imagery can do to enhance our practice and to maximize our patient's potential, maximize rehabilitation outcome, is to add something extra to what we usually do. And if we wanted to improve muscle strength, for example, if we wanted to improve balance, for example, if we wanted to improve upper extremity function, for example, rather than providing our conventional treatment or conventional therapies or approaches, we could actually add an extra treatment, and that would be mental imagery, all right, in order to enhance motor recovery, particularly in patients with stroke or other neurologic problems. There are certain variables of mental imagery that we can use in order to improve strength. The characteristic of imagery intervention is the first one. Characteristic of imagery intervention, which is considered the most important variable in mental imagery, is the first variable. Evidence suggests that higher mental effort yielded more strength, more improvement in strength than low mental effort and more than those not having mental imagery training. So there's already a research before that if you put higher mental effort, if patients will provide more mental effort imagining the task that he has to practice, it will yield more improvement in strength rather than low mental effort. Okay. Internal imagery is better than external imagery, all right, for enhancing performance, especially when it is combined with other cognitive techniques such as relaxation, goal setting, hypnosis, and self-talk. So it is quite important that we use internal imagery rather than external imagery. Another variable for improving strength, all right, is training duration. Shorter mental imagery for around 3 to 6 weeks can induce greater effects on strength performance than longer mental imagery, around 7 to 12 weeks. So it's very important that the training duration should be around 3 to 6 weeks only. Short term, around 3 weeks of motor imagery strength training can increase motor evoked potentials. If there are 3 sessions of mental imagery per week, they found that it is more effective combined with once or twice a week mental imagery session, according to Wakefield and Smith in 2011. Giving MI or giving mental imagery for 3 sessions is more effective than lesser number, all right, in improving, all right, muscle strength, according to previous research. Now, how about the types of skills? External imagery supports performance of only one task. Internal imagery serves multitask performance. Internal imagery seems to be more effective as well when training for close skills, all right, compared with open skills. All right. When we're talking about close skills, these are skills or tasks that are performed in a constant environment. All right. Constant environment, it means that the environment, the surface, the objects, and the people remains constant or are not moving. It is a constant environment in which all of the variables are somehow controlled, in which the factors that can affect motor performance are actually controlled or limited. Whereas in an open skills, all right, when training for open skills, it means that external imagery is more effective. And when we perform tasks in an open environment, it means that the patient can be placed in an environment in which people or objects or surface can be moving or dynamic. Definitely, during early stages of motor learning, we have to practice skills in a closed environment. And that is when internal imagery is more effective. However, if we wanted to develop skills that are more dynamic, that are more versatile, and more automatic, we have to use external imagery, and it has to be done in an open environment. All right, in order to make the patient be able to respond, react effectively in different situations or different in different challenges, all right, that is present in an open environment. Because in an open environment, all right, patient may be confronted with different challenges, and that would include presence of moving object or presence of persons in the environment or presence of a moving surface. And the patient should be able to anticipate and react accordingly. So, external imagery may be more effective, all right, when practicing open skills, which is usually being practiced during the later stages of training, all right? When we wanted to teach the patient to be more adapted or more flexible and more dynamic with his or her uh, task or motor activities. Internal imagery for rehearsal, okay, is more effective for rehearsal program in sports, whereas external imagery will be effective when practicing a new skill or a different motor experience. All right. So, internal imagery is more related to sports, whereas external imagery will be good for new and different experience. So, for example, our patient suffered from stroke or traumatic brain injury, and we want them to relearn, all right, to relearn the task or to learn a new task, then external imagery will be more effective, right? When deciding what type of mental imagery or motor imagery is uh, to be used. Okay, so the type of skill is very important as well. Another variable for mental imagery to be effective in improving strength would be the skills level. All right. For more experienced or elite athletes, for patients who are more active, more athletic, it is recommended that we use internal imagery. All right? Most of literature indicates a greater effect of internal imagery on muscle strength than external mental imagery. However, all right, for those patients with lesser ability or less athleticism, and those patients with neurologic impairments, then external imagery will be more effective. Considering all of the recommendations that I have summarized, all right, in my previous slides, there are areas for further research about mental imagery or motor imagery. Aspects of mental practice or mental imagery dose is one factor. We need to consider that the mental practice dosage may be established among healthy individuals, but in stroke patients, it is not yet clearly researched. Okay. Another area for further research is adherence to the mental practice program. It is very difficult to measure the adherence of patients in terms of the mental practice, whether they're really focusing on the task that they need to imagine, in the motor activity that they need to visualize on their head. All right. So the adherence to the mental practice program is one of the limitations or one of the challenges when making use of this technique. Comparison between responders and non-responders has to be done as well. All right. Distractions during mental practice or during mental imagery can also be another factor that can influence its effectivity or its efficiency. Underlying mechanisms of mental practice or mental imagery is another factor that needs further investigation. The impact on mental practice on perspectives of neurophysiological and hormonal adaptations and comparisons on different mental imagery interventions and the effects of these interventions for athletes on competitive situation also warrants further investigation. So these are some areas for further research about mental imagery that we have to consider, because mental imagery or motor imagery is one of the techniques that has been established long before. All right. Unfortunately, it is one of the techniques that we use in neurologic rehabilitation that is less researched upon. Okay. However, there are several research which has shown the effects of this particular technique in combination with other techniques. So therefore, in conclusion, mental imagery can be a very good way by which we can improve or we can further um, maximize our patient's potential and increase the rehabilitation outcome. So with that, I am going to conclude my presentation. These are the references that I used, and I would like to acknowledge Professor Dr. Jaya Barathi, the principal of Sri Abhirami College of Physiotherapy from Coimbatore, Tamil Nadu, India, for inviting me over. And a special mention to Dr. Nanda Kumar Ramasamy, the principal of Venkateshwara College of Physiotherapy from Gobi, Tamil Nadu, India, for acting as my liaison to Professor Jaya Barathi. All right. And aside from that, I would like to thank the entire organizing committee for inviting me over in this webinar series. For the participants, you may scan the QR code, all right, to get a copy, or you can use the URL that I have included in my presentation, all right, so that you can get a copy of this lecture. With that, let me conclude my presentation. Thank you and mabuhay.
Oh, thank you, sir. Thank you, uh, thoughts, sir. Really very good, wonderful performance regarding internal and external mental imagery techniques that is used for the post-stroke patients. Uh, We have a few questions, sir, regarding what
Yes.
are the imagery techniques for improving functional recovery of hand. So
Can you repeat it?
can you list out a few motor imagery techniques for improving the functional recovery of hand?
Of the hand. All right. Okay. Here's the thing. Motor imagery or mental practice is just a practice of the usual activities or movement that we do. For example, I wanted to improve, for example, the grasping ability. So what you do, if it is an internal imagery, I will just ask the patient to close his eyes, all right, seated on the chair that he or she is usually sitting in front of a table. And in front of the table, I'll place there a glass of water, for example, a ball, all right? And I'll ask the patient to imagine that there's a ball in front of her or him, and imagine his hand, all right, approaching the ball and grasping the ball. So mental imagery is just like that. They need to imagine how the fingers will look like, how the elbow will look like, how the shoulder will look like, how the hands will be approaching the ball, imagining that the hands is approaching the ball to grasp the ball which is placed on top of the table. That is internal imagery. All right, because when you're doing an internal imagery, when you're doing mental or motor imagery, you are simply imagining the movement or the task that you are going to perform. If I wanted to make a step, for example, I want to do gait training, what I wanted to do is ask the patient to stand and then imagine that he is going to place his foot in front of him. All right. So we are practicing a stepping motion. So we'll ask the patient, imagine that you are going to move your foot in front of you. Imagine. Now try to imagine the position of your hip, imagine the position of your knee. Imagine the position of your ankle and foot as you place your leg in front of you. That is what mental imagery is. That is what motor imagery is. If it is internal imagery, you imagine that you are looking at your foot, and your legs is moving in front of you. That is internal imagery. Now, what is external imagery? In external imagery, you will just have to tell, imagine you are watching a video and you are stepping your foot, moving your foot in front of you. That is external imagery. So, in internal imagery, you are imagining the different segments of your body, the different joints of your body moving. It's as if that there is a video or a camera in front of your head and you are looking at the different segments of your body as they move. Whereas in external imagery, you are watching yourself. You are imagining that you are watching yourself doing the movement. That's the difference. Now, after mental imagery, which will usually last around 10 to 15 minutes, you do physical practice. Okay? What do we mean by physical practice? They will do the actual movement after they do the mental imagery, mental practice. So I keep on imagining that I'm going to grasp the ball. It will last for 15 minutes. I will have to repeat it over and over again. I need to create a mental picture in my head. I need to create a mental program in my head that this is the way that I need to move my shoulder. I need to move my elbow. I need to move my hand. This is how I'm going to move it. Okay? I am creating a mental picture. It is mental imagining, motor imagery of what I am going to do. All right? And after the mental imagery, the motor imagery, after I keep on repeating it, that is mental practice, because practicing it over and over again inside your head is mental practice. Once I'm done with the mental practice session, I do physical practice of whatever task I imagine. And according to research, we have to combine mental practice or motor imagery plus physical practice in order for it to be effective. And they found out that mental practice plus physical practice is more effective than physical practice alone. There's a lot of systematic reviews which already proven that a combination of mental practice, motor imagery, plus physical practice is more effective than conventional rehabilitation or physical rehabilitation alone. I hope I was able to answer the question.
Yes, sir, perfectly. Well said, sir. Thank you for your elaborate explanation, Dr. Labo. So
Okay.
I will now ask Ms. Kalpita to give the vote of thanks. So thank you, sir, for accepting our invitation for the International Webinar Series 4. Thank you very much.
It is my pleasure to be speaking and to be invited as a webinar speaker. Uh, and again, thanks to Sri Abhirami College of Physiotherapy, all the board of directors and the administrators of this particular College of Physiotherapy of India. I do appreciate your invitation, and I hope that all of us will be able to go get through with this COVID pandemic currently happening all over the world. And it is my pleasure to be sharing with you some of my expertise, particularly in neurologic rehabilitation and the use of mental practice in stroke rehabilitation. Thank you very much,
Thank you.
Professor.
Thank you, sir. Thank you, ma'am. A warm good evening to one and all present here. I am Ms. Kalpita, coordinator of this event, and it's my great pleasure to deliver my vote of thanks on this International Webinar Series 4, conducted by Sri Abhirami College of Physiotherapy. On behalf of Sri Abhirami Institution, it's my immense pleasure to thank a resource person, Dr. Hernan Labao, lecturer, Department of Physiotherapy, Faculty of Health and Life Science, Malaysia. We are really enlightened with your knowledge and presence of valuable information and excellent presentation on post-stroke balance and motor recovery. Thank you, sir. I express my gratitude to our chairman, Dr. P. Periyasamy, sir, Sri Abhirami Group of Institution, and Board of Director, Dr. Kundavi Devi, ma'am, Dr. Sendil Kumar, sir, Dr. Balamurugan, sir, Dr. Uma Devi, ma'am, Dr. Sujirita, ma'am, for constantly motivating us in every occasion. Thank you, sir. Thank you, ma'am. I would like to extend my sincere thanks to our principal, Dr. Jayabharati, ma'am, for her valuable guidance and support to organize this international webinar series successfully. Thank you, ma'am. I also extend my thanks to our EDP department, Dilip sir, for standing firmly for successfully completing this event. Thank you. A heartfelt thank you to our students and delegates for active participant with their warm words and kind message. Thank you. And we move to the end of today's seminar. I request all the participants to kindly fill up feedback form after this session. Thank you.
Okay, so we will end up the session. Dilip, sir.
All right. Thank you very much. Bye.
Thank you, sir. Thank you, Dr.
Bye.
Labo.
Thank you. Thank you. Bye
Bye-bye.
bye.